This topic is hyperthyroidism. Hyperthyroidism is a condition that occurs following sustained hyperfunctioning of the thyroid gland. Now, the thyroid gland typically produces two different types of hormones, referred to as T3 and T4. When these hormones are abundant, the body's metabolism is increased, and we can experience a sympathetic response in the form of an elevated heart rate, blood pressure, and temperature. Normally, decreased levels of T3 and T4 will lead to a release of thyroid-stimulating hormone from the anterior pituitary gland in the form of a negative feedback loop. As we can see on the image in this slide, increased levels of thyroid-stimulating hormone will cause increased production of T3 and T4 within the thyroid gland and will lead to increased levels throughout the body. Hyperthyroidism occurs when there is an inappropriate increase in thyroid hormone levels. And there are two common causes. The first is Graves' disease. Graves' disease is an autoimmune disorder in which autoantibodies attach to thyroid-stimulating hormone receptors, which increases the production and release of T3 and T4. And the other cause is thyroid tumors, which can cause unrestricted growth of thyroid gland tissue, which again leads to increased production of these thyroid hormones. To diagnose hyperthyroidism, the healthcare provider will assess for increased levels of T3 and T4 while also looking for a decrease in the amount of thyroid-stimulating hormone. A radioactive iodine uptake test can also help us to confirm diagnosis. The reason that this test works is that iodine is essential for thyroid hormone production. So if we give a very small amount of radioactive iodine, we can measure the amount that's taken up by the thyroid gland tissue, and if this amount is more than expected, we get a positive diagnosis for hyperthyroidism. Increased thyroid levels within the body result in an increased sympathetic nervous system response and increased metabolism. Remember, the sympathetic nervous system helps us to control our fight or flight response. Therefore, we can expect our symptoms to mimic those of an activated sympathetic nervous system. And we can remember these symptoms by thinking of the mnemonic sweating. Essentially, the client will have excessive sweating, unexplained weight loss, exophthalmos, which means the eye protrudes from the eye socket, amenorrhea or irregular menstrual cycles, tachycardia or tremor, intolerance to heat, nervousness and insomnia, or goiter and GI distress. When the sympathetic nervous system is constantly stimulated, the cells within the body begin to fatigue and can lead to a number of complications. Overstimulated heart muscles can contribute to the development of different arrhythmias, including tachyarrhythmias, atrial fibrillation, and ventricular fibrillation, which is life-threatening. And when these heart muscles that are being overworked eventually begin to wear out, the client can develop manifestations of heart failure, such as peripheral edema and trouble breathing. Thyroid storm is a severe hypermetabolic state that can have exaggerated symptoms of hyperthyroidism, and it's something that we're going to discuss a little later on in this presentation. Overstimulated neurons within the brain can increase the client's risk for developing seizures. And because the eyes are protruded and the eyelids have trouble closing, the client can develop corneal irritation and eye injury. Our first goal with these clients is to control the level of sympathetic overactivity within the body and reduce thyroid hormone levels. We want to block actions of sympathetic activity within the heart, and we can do this by administering beta-adrenergic blockers like propranolol. These medications will help to reduce the heart rate and improve cardiac output. Additionally, we can administer anti-thyroid medications like methimazole and propylthiouracil. These medications work to decrease thyroid hormone levels by decreasing thyroid hormone synthesis. It's important to note that an adverse effect of these medications is the development of agranulocytosis, or decreased absolute neutrophil counts. Therefore, the nurse should monitor for neutropenia and report any symptoms of infection immediately to the healthcare provider. Long-term therapy focuses on reducing thyroid hormone production, and this can be accomplished one of two ways. The first way is through radioactive iodine therapy, where we give the client a very high dose of radioactive iodine, which is then taken up into the thyroid gland. The radioactive iodine gives off radiation, which goes on to destroy thyroid gland tissue, ultimately decreasing the amount of thyroid hormone released from the thyroid gland. Another option for the client, if they would prefer not to have radiation, is to have a thyroidectomy or surgical removal of the thyroid gland. While providing care, the nurse should frequently assess the client's vital signs, especially the heart rate and blood pressure, as they are more likely to be elevated. We should provide a quiet, restful, and cool environment to help promote client comfort. Fluid should be encouraged to help prevent total fluid volume loss, especially due to excessive sweating. A high carbohydrate, low fiber diet should be provided to help restore energy sources that have been lost. The client should avoid caffeinated beverages and spicy foods, which can exacerbate symptoms of hyperthyroidism. And artificial tears can be provided to the client to help prevent eyes from drying out. Because clients receiving radioactive iodine therapy can emit radiation to others, the client should be taught to avoid contact with close family and friends for a period of several days following therapy. To accomplish this, the client should avoid sharing utensils with others, wash their personal clothes separately from other individuals, sleep in a separate bedroom, utilize a separate bathroom, and make sure to flush at least 3 times before leaving, and avoid pregnancy for 4 to 6 months following administration. A thyroidectomy may be necessary to permanently reduce thyroid levels within the body and can be accomplished through surgical removal of part or all of the thyroid gland. Now, the thyroid is located in the neck anteriorly to the larynx and vocal cords. When the thyroid gland is removed surgically, soft tissue within the neck is manipulated and can begin to swell. If the amount of swelling becomes too much, this can lead to upper airway obstruction. Therefore, our priority following thyroidectomy is to make sure that the client is able to maintain their airway. Suction and oxygen should be available at the bedside at all times to remove secretions from the mouth and oral cavity and to increase the amount of tissue oxygenation. Additionally, an emergency tracheostomy kit should be made readily available in the event that the airway does become completely obstructed. And the client should be positioned in a semi-Fowler position with pillows supporting the head. The nurse should monitor for a number of complications following a thyroidectomy. First and foremost, we should assess for any symptoms of respiratory distress, such as restlessness, hypoxia, and tachypnea. Just like any type of surgery, the client is at risk for hemorrhage, and with a thyroidectomy, this can appear as rapid swelling within the neck, constant swallowing by the client, meaning the client is clearing blood from the throat itself, and the presence of a blood-saturated dressing. If laryngeal nerve damage occurs during thyroidectomy, the client's vocal cords can collapse on top of each other, and the client can develop stridor. Stridor is an adventitious lung sound that sounds like high-pitched whistling and is an indication that the airway is at risk for complete obstruction. Due to the location of the parathyroid gland, we should also monitor for hypocalcemia and tetany due to hypoparathyroidism. The parathyroid gland is in close proximity to the thyroid gland and can be damaged or accidentally removed during thyroidectomy. If this occurs, the body can undergo a significant reduction in calcium levels. Therefore, we should monitor for signs of this, which include numbness and tingling throughout the body. And lastly, thyroid storm can occur if the thyroid gland is damaged during the thyroidectomy, leading to a sudden increase in the amount of thyroid hormone being released into the body. The client should be taught that mild hoarseness can be expected 3 to 4 days following surgery due to edema, and this hoarseness is not an emergency that needs to be reported to the healthcare provider. We can anticipate long-term thyroid medication therapy to replace thyroid hormones that are not being produced. Now, if the client has had a partial thyroidectomy, they still have a part of the thyroid gland remaining, meaning they may be able to maintain adequate levels of thyroid hormone within the body. However, if this level is inadequate, or if the client has had a complete thyroidectomy, they will most certainly need long-term thyroid medication replacement therapy. To finish our discussion on hyperthyroidism, let's take a closer look at thyroid storm. So thyroid storm again can occur one of two ways. It can be a complication of hyperthyroidism itself, or it can occur during a thyroidectomy when the thyroid gland is damaged, leading to an increase in the release of thyroid hormone into the body. A significantly high thyroid hormone level can lead to the client developing a severe hypermetabolic state. Essentially, the client may not be taking their medications appropriately. This hypermetabolic state can cause life-threatening symptoms of hyperthermia, tachycardia, confusion, seizures, shock, and coma. Therefore, if thyroid storm develops, the nurse should immediately notify the healthcare provider and implement interventions to help reduce the client's heart rate, blood pressure, and temperature.